In episode 7, we are going to talk about perioperative pulmonary complication and risk assessment. So, what are the preoperative risk factor of postoperative pulmonary complications? Uh, Preoperative risk factors, as shown in this chart, are age, smoking, generalized health status of the patient, nutritional status, chronic lung disease, upper respiratory tract infection, heart failure, pulmonary hypertension, obesity, obstructive sleep apnea. Intraoperative risk factors are surgical site, that is type of surgical incision or type of surgical procedure, type of anesthesia and duration of anesthesia. Postoperative risk factors are immobilization and inadequate pain control. So we have to try to control and modify all these risk factors. For example, in postoperative patients, avoid prolonged immobilizations, uh, concentrate on adequate pain control. Now, what are the preoperative risk factors? Age. Age, you can see, age more than 50 years was an important independent factor in this study published in Annals of Internal Medicine. When your patient's age is more than 80 years, odds of developing pulmonary complications is 5 times more than the normal patient. When it is 70 to 79, it is more than 4 times. 60 to 69, age around 2.5 times than the normal people. 50 to 59, more than 1.5 times risk factor is there. If your patient is chronic smokers, then the relative risk is 1.73. That is almost 2 times patient is higher chance of developing postoperative pulmonary complication than the normal patients. If your patient is obese, now what are the effects of obesity? Due to obesity, your lung volume is reduced, your functional residual capacity is reduced, your airway radius is reduced. Due to all this, there are high chances of lung collapse and ventilation perfusion mismatching. However, in studies, obesity has not been consistently shown as the risk factor of postoperative pulmonary complication, and obesity should not affect the patient selection for otherwise high risk procedure. Obstructive sleep apnea. As you see in obese patients, there are very commonly you found the obstructive sleep apnea. Now, due to this obstructive sleep apnea, there is higher chance or higher incidence of unplanned ICU transfer to the patient. It increases your patient's length of stay. High risk of pneumonia is there, and high risk of respiratory failure is there. And odd ratio for postoperative respiratory failure is almost 1.95. That is 2 times higher risk than the normal patient. So, every obese patient should be screened for obstructive sleep apnea. If your patient is a known case of no, heart failure or known history of heart failure, there is a higher chance of postoperative pulmonary complication, and odds ratio of that is around 3. That is 3 times higher chance than the normal patient of developing postoperative complication, because heart failure can cause pulmonary congestion. It leads to decreased compliance of the lung. Low lung volume leads to decreased airway radius. Again, it causes atelectasis, and due to that, there is a higher chance of ventilation perfusion mismatch. Now, type of surgery or surgical site or incision site is the independent risk of postoperative pulmonary risk factor. Remember, like upper abdominal incisions has a almost 19.7% risk of developing postoperative pulmonary complication. Esophagectomy alone has a 18.9% risk of developing postoperative complication. Lower abdominal surgery is risk free compared to upper abdominal surgery, but they still have higher chance of almost 7.7% risk of developing postoperative pulmonary complication. General anesthesia carries higher risk for developing postoperative pulmonary complications. So, how to evaluate or preoperative evaluate? You have to see or take proper history of the patient, whether your patient is having COPD, whether your patient is having asthma, whether your patient is obese. Sometimes you can use the risk indices, which is very important in determining the perioperative risk, like aerosolar respiratory failure index, CANET risk indexes, ASA class more than 2 is the independent risk factor for developing postoperative pulmonary complication, or you can use the Gupta calculator, which is freely available on net. In selected cases, you can use spirometry, lung volume study, or polysomnography in case of obstructive sleep apneas. Now let us see how to use it. This is the Arozulla Respiratory Failure Index. Now every risk factor has given some point. For example, types of surgery: when you are operating for aortic aneurysm, the point is 27. Thoracic surgery carries points of 21. Neurosurgery, upper abdominal or peripheral vascular surgery carries point of 14. Neck surgery 11. Emergency surgery 11. Patient nutritional status or generalized health station: when your albumin is less than 3, it carries a 9 point weightage of postoperative pulmonary complication, that is malnutrition is associated with pulmonary complication. If your patient's creatinine is high, it carries 8 points. If your patient is having partially or fully dependent functional status, it carries a point of 7. If your patient is having history of COPD, 6 points. If your patient's age is more than 70 years, 6 points. Between 60 to 69, 4 points. Now sum total of your score, if it is less than 10, then chances of developing postoperative respiratory failure is in the range of 0.5%. 11 to 19, 1.8%. 20 to 27, 4.2%. 28 to 40, 10.1%. More than 40, your patient is having 26.6% chance of developing postoperative respiratory failure. So you can assess your risk benefit ratio according to that. Another risk indices you can use is kinetic risk indices, which shows age. When your patient age is less than 1, then the odds ratio is 1, that is risk of almost 0. Age is 51 to 80, then odds ratio is 1.5, that is 1.5 times of risk of developing postoperative pulmonary complication, and risk score is given for that is 3. More than 80, risk score is 16. Preoperative obesity, or sorry, it is preoperative oxygen status. If it is 100%, then risk score is 0. 91 to 95%, you can give the risk score of 8. Less than 90%, then risk score is 24. Respiratory infection in last month, that history of respiratory infection in last month carries weightage of 17. Preoperative anemia, when HB is less than 10, it carries risk of point score of 11. Surgical incision, if it is in upper abdomen, then it is same as normal person, but surgical incision in upper abdomen in patient with more than 80 years of age carries a point value of 16. When your duration of surgery is more than 3 years, it carries point value of 24. Emergency surgery carries points of 17. On that, if your total point score is less than 26 points, then it is the low risk for developing postoperative pulmonary complication. If it is 26 to 44, then it carries a moderate risk, and if it is more than 45, it carries high risk. And another risk assessment method is Gupta Score, which is available online, and you can use that calculator. It uses whether surgery is emergencies or not, ASA class, preoperative functional status, is type of procedure, whether there is a preoperative sepsis or not. And based on that, it calculates the risk of developing postoperative pulmonary complication. Now, in case of OSA, how to analyze the risk? If severity based on sleep study is none, then 0 point, mild 1, moderate 2, severe 3. Invasiveness of the surgery: superficial surgery under local and peripheral nerve block, risk score is 0. Superficial surgery with moderate sedation and general anesthesia, risk score is 1. Peripheral surgery with spinal and epidural, 1. Peripheral surgery with general anesthesia, risk score of 2. Airway surgery, risk score 2. Major surgery with general anesthesia, risk score is 3. Airway surgery is again risk score of 3. So based on that, total point is calculated. Requirement of postoperative opioids is given risk score of 3. If your points is less than 4, then it is a low risk of developing postoperative pulmonary complication. 4, increased risk. 5 or 6, it's a significant risk. So how to assess risk assessment in non-resective lung surgery, that is any other surgery than the lung resection. You have to, of course, take history and physical examination, seeking whether there are any risk factor for pulmonary complication. If there is no risk factor, you can directly proceed for surgery. If there is a risk factor, identify risk factor, explain to the patient just to see whether it is a modifiable or not. If patient is having high risk, then do chest x-ray. Chest x-ray is not that useful, but still you can do it. uh, you can use pulmonary function test selectively in high risk patient. If your patient is having abnormal pulmonary function test, consider him a high risk. If it is normal with risk factor of having preoperative or postoperative pulmonary complication, consider it as a moderate risk. So all patients should be evaluated for presence of COPD. When age is more than 60, ASA class is 2, more than 2, that is the independent risk factor. When patient functionally is poor, patient is having chronic heart failure, obesity and mild and moderate asthma. Higher risk of complication when there is a prolonged surgery, abdominal surgery, thoracic surgery, neurosurgery, head and neck surgery, vascular surgery, aortic aneurysm, emergency surgery, and patient is going general anesthesia. Nutrition status is important. You can see from the various risk indices. Then your albumin level is less than 3.5 or less than 3, has higher chance of developing postoperative pulmonary complication. Patients who are having higher risk of complication should have deep breathing exercise or incentive spirometry before surgery for at least a week, and they should be taught how to do it postoperatively. And selective use of nasogastric tube, that is nasogastric tube or rice tube, is an independent risk factor of developing aspiration pneumonitis or postoperative pulmonary complication. The patient with higher risk should not go out of the operation theater with rice tube unless and until it is absolutely necessary. Preoperative spirometry and chest radiography, that is preoperative pulmonary function test, should not be used routinely, but can be used in selected patients which are having higher risk of developing postoperative pulmonary complication. Right heart catheterization and total parenteral nutrition should not be used to reduce pulmonary complication, but right heart catheterization can be useful in patient who is showing very high pulmonary pressure on your echocardiogram to exactly determine the postoperative pulmonary risk. Preoperative spirometry value unproved. Okay, try to reduce nutrition requirement. What are the various strategy to reduce the postoperative pulmonary complication? Ask your patient to stop smoking. Smoking cessation is the most important modifiable risk factors. You can treat your or teach your patient spirometry or various lung expansion modalities. Avoid pancuronium or neuromuscular blockage as long as you can. Try to use neuraxial blockage. There are evidences that laparoscopic surgery is helpful in reducing the postoperative pulmonary complication. To try to do those patients laparoscopically if you can. Preoperatively give nutrition support. Pulmonary artery catheterization has no much value in today. Avoid rice tube after abdominal surgery to reduce postoperative pulmonary complication. Now, which patient should have preoperative pulmonary function test evaluation? Patient with known pulmonary disease, planned lung resection, or patient is a heavy smoker. Then only there is some use of having preoperative PFT evaluation. It should not be done in every cases. Now, whenever there is anesthesia, is there, it decreases mucociliary clearance, it causes diaphragmatic weakness, it reduces ventilatory drive. So all this can use to shallow breathing, cough and atelectasis, ventilation perfusion mismatch, hypoxia, and all this can lead to postoperative pulmonary complication. That is why just general anesthesia is an independent risk factor of postoperative pulmonary complication. So you should be very vigilant for that. Adequate analgesia and motivation are necessary in postoperative care. Cough and deep breathing exercise should be taught preoperatively and should be continued aggressively postoperatively. Incentive spirometry should be used postoperatively. CPAP or BiPAP for few minutes every 2 to 4 hours has found to be useful. Otherwise, that you cannot do much. In case of COPD, you have to assess the patient with PFT, ABGs, try to avoid smoking. Patient who has a sputum production use antibiotics 3 to 5 days pre-op, that is established pneumonias. There is some role of systemic corticosteroids, prednisolone 40 mg daily for 3 days. Bronchodilator should be used routinely. In case of asthma patient, history is very important. Patient should ideally be completely asymptomatic for 6 months. You can use the bronchodilator only perioperatively in those patients. If patients are symptomatic and your pulmonary function test are abnormal, use prednisolone 40 mg daily for at least 3 days pre-op and 3 days post-op. If patient is well post-operatively, discontinue it. Otherwise, you have to continue prednisolone. Obesity is independent risk factors. We have already discussed about obstructive sleep apnea. You can do various intervention, like always try to keep patient in upright position. Do not use oxygen very oftenly. Oxygen can lead to complication in this patient, so use oxygen only when it is needed post-operatively. CPAP, BiPAP, incentive spirometry, basically you have to concentrate on chest physiotherapy. If you see, you either you can stratify your risk, and pulmonary problem should be modifiable only by two things, that is the preoperative and postoperative spirometry and chest physiotherapy. So that is the most important intervention you can do. Thank you very much.